rheumatic heart disease, and it is from the classroom to the bedside. So what we have learned in class, how can we then translate it to the classroom? I'm in a strange place, so you can always stop me if you can't hear me. So this lecture is based on the fact that you probably have had the lecture on rheumatic fever and what then leads to rheumatic heart disease. So I will take it from the point where we already have damage to the valves giving us rheumatic heart disease. But let me go back and just remind ourselves what rheumatic fever is by definition, and what rheumatic heart disease. Then quickly we'll go through the conditions. And as it said, rheumatic fever is a non-suppurative sequela of a sore throat that was not treated, of an upper respiratory tract infection due to beta hemolytic streptococcus, which was not handled well. You don't get it the same time you have the sore throat, but you get it after. So it is a post-infectious condition. And it is not infectious. I can't just transfer my rheumatic fever to you. So it is considered a connective tissue disease. It is inflammatory and it is diffuse. It is a diffuse inflammatory condition, and it involves the connective tissues. And most of these connective tissues then are spread all over. So we have them involving the heart, the joints, the blood vessels, and the subcutaneous tissues. And this is what usually forms the major criteria, and we also have some minor criteria. That's just a revision. This background information also is just to tell you that rheumatic fever still remains a condition that is commonly seen in the young, but in outside countries it's coming down. The prevalence is coming down, but it's still common in the low and middle income countries. It's still a leading cause of cardiovascular morbidity and also mortality. Morbidity means that it makes you sick for long. Mortality means it is capable of killing you. And as it is, the etiology, actually the precursor is a streptococcal bacteria of the group A. There are several things which make somebody get a rheumatic fever and rheumatic heart disease and another doesn't. So we think that maybe there is some constitutional factors or environmental factors like overcrowding, like lower socioeconomic status, like malnutrition, things that can, and the fact that if you have lower socioeconomic status, then getting the sore throat, and so they still can afford it, but they ignore the sore throat and they get rheumatic disease. If I got typhoid, why don't the thing is, it is thought that I think probably I've given this lecture before, that you get tissue injury. Yeah. And this is because some components of the bacteria resemble some components of the human tissues. And so you have the concept of one antigen mimicking or simulating another antigen. And it is thought that the cell wall of the streptococcus, which has three components. It has a protein component, a carbohydrate moiety, resemble the components in the human tissues. Outside one resembles the human joint, and then the M proteins, the M proteins, the mucopeptide proteins of the cell wall resembles the myocardium, and the valvular tissues have an intergenic moment. The carbohydrates, they resemble the carbohydrates, and the cytoplasm resembles some parts of the human myocardium, and the sarcolemma and the subthalamic the cell membrane involved in affects the myocardium, and then the valvular tissues, which is what we are talking about today, is from the carbohydrate group moiety, that is from the cell wall. So that is basically the mechanism of injury, and that's just the details. But rheumatic fever and rheumatic heart disease in the pediatric age group, usually they get this sore throat by around 5 years or so, and if it is not treated, then we get inflammation. So the inflammatory process involving most of the times the left side tissues gets the aortic and the mitral valve. So initially between the age of 5 to 10 years, you get aortic and mitral regurgitation, with mitral regurgitation more common than aortic regurgitation. Then later on, you get mixed lesion, you get the mitral regurgitation and aortic regurgitation, but some stenosis starts to set in. So we do get children with stenosis, and then much later on, in the older patients, like the one we were doing today, is a 30-year-old nurse with mitral stenosis, and so the older they get more stenotic lesions, and this is just how the anatomy is. And mitral regurgitation basically is the commonest lesion, and what happens is that the valve gets thickened, it gets edematous, so it can't close well. So when it can't close well, the mitral valve has got an anterior and a posterior leaflet. This is a picture, and this is the posterior leaflet close to the posterior wall, and this is the anterior leaflet. So when this valve gets affected, and this is the left ventricle, and this is the left atrium. So blood flows in from the left atrium, enters to the left ventricle, the valve then closes, and so the blood has to leak back. But when you get rheumatic mitral regurgitation, these valves are loose. You can see they are loose, and so blood leaks back. When the valve closes, the blood leaks back. And just a little bit of the physiology. The mitral valve opens to allow blood to come in diastole. Then after the blood has come in, it closes and it pumps blood to the aorta. So when it closes in systole, and then the aorta is has to also open in systole. so that this blood is taken to the rest of the body. So in mitral regurgitation, when the valve is supposed to close in systole, we start to have a leak. And this leak, the blood leaks back to the left atrium. The left atrium is a posterior structure. We find it in the left axillary line, the mid-axillary line and the posterior axillary line. That is where the left atrium is situated, and it's a posterior structure. If you remember that anatomy of the mediastinum, we have an anterior mediastinum, a middle mediastinum, and a posterior mediastinum. In the posterior mediastinum, we have the aorta down and the esophagus, and around that is also the left atrium. So the left atrium is a posterior structure. So this blood will leak back to the left atrium. So it will leak back to axilla. So the murmur of mitral regurgitation occurs when the blood is supposed to pump. The murmur of mitral regurgitation is a systolic murmur. The murmur of mitral regurgitation is a systolic murmur, and it starts when the heart starts to contract, and it ends when the heart stops to contract. So it occupies the whole of systole. So the murmur of mitral regurgitation is a pan-systolic murmur. So my first finger up, the murmur of mitral regurgitation is a systolic murmur. The murmur of mitral regurgitation is a pan-systolic murmur. It goes throughout the whole of systole. The murmur of mitral regurgitation is a pan-systolic murmur that can also be heard in the axilla and even in the back. It radiates to the axilla and the back. Those are the features of a mitral regurgitation. The other clinical feature which we can derive from the histology, from the physiology, is that when blood leaks between the left atrium and the left ventricle has a job of keeping this blood, making sure that it pumps at least something out to the outer so that the child can walk or eat or do something. With time, the left ventricle increases in size, and with time it dilates. The left ventricle is basically felt, the activities of the left ventricle is vertically felt at the apex. So you will get a systolic murmur at the apex. So the murmur of mitral regurgitation is an apical systolic murmur, apical pan-systolic murmur, apical pan-systolic murmur radiating to the axilla. So if you come to the clinic and you appreciate a murmur and you time it and it is in systole and you can still appreciate it even towards the axilla, your diagnosis is mitral stenosis, and you can make it from a clinical examination. You don't need an echo to make that diagnosis. You can make that diagnosis from a clinical examination. Are we still together?
Yes, sir.
Okay. So these are the clinical presentations of mitral stenosis. This thing used to play. It has refused to play, so I will leave it alone. But they will present with poor exercise tolerance. You tell them to put in more exercise, more energy. They don't have it because they are fatigued. They can't send as much blood to the rest of the body because most of it is going back to the lungs and the left atrium. So they have poor exercise tolerance. They have cough and difficulty in breathing because most of this blood goes back and fills the lung. And they have palpitation because there's so much blood around too. And they have chest pains because the muscles have to get bigger. So in terms of what their complaints, they are fatigue, they have poor exercise tolerance, they don't put as out much weight. You tell them to do something and they are coughing and they have difficulty in breathing. Adults, we say they have orthopnea, they have palpitations, and they have chest pains. Those are the problems they come to you when they walk in the clinic. And when we examine them and we feel for the pulses are usually fast and of low volume. The jugular venous pressure is not elevated, but the most things is at the apex. It is a hyperactive apex. It pushes your hands up as you put your hands there, and you really can't localize it. It is heaving and hyperactive. The heart sounds, usually when we examine also the heart sounds before we examine the mammals, and usually in mild regurgitation it is within normal limits, but when the regurgitation gets severe, the second heart sound is accentuated. And as I said, we have a pansystolic murmur that radiates to the axilla. So if you come on Friday and we have a patient with mitral regurgitation, you can actually just examine those patients and say, Prof, I got it. This must be mitral regurgitation. These are the findings that I got. So the investigations that we do, a chest X-ray will show me a big heart, and the left side is with the one which will be prominent. And because blood gets back to the lungs to the left atrium and the pulmonaries, the pulmonary vascular markings are increased. So even from the physiology, you can understand some of these investigations. Okay, so that if you are the only doctor in Cabernet and you do a chest X-ray, you had some noise, and you do a chest X-ray and you see a big heart with increased pulmonary vascular markings, and you had a mama which was systolic, and the child is more than 5 years, chances are this child has rheumatic mitral regurgitation. You will still find an ECG in Cabernet. Nowadays, they are all there. And so the ECG will show you left atrial enlargement and left ventricular hypertrophy. Then the echo will define the pathology, but it will also give us the severity, which of course we had looked at, gotten it from clinicals. It will also give us the severity, okay? So it can be mild mitral regurgitation, it can be severe mitral regurgitation. We try to make sure if I get such a child, the first thing I do is I say, I don't want you to get another rheumatic fever because it is going to get worse. So I must treat that sore throat, and I must prevent another sore throat because it will go back and damage the heart. Then if this child has already gone into heart failure, then we will do heart failure treatment, which is another lecture. But surgically for children, we want them to repair the valve, but sometimes they can't repair the valve, and so they have to replace the valve with a metallic prosthesis. If they put a metal in a child, the child will grow, but the metal will not grow. So I have an 8-year-old with severe mitral regurgitation. I remove and put a metal in the heart. The child gets better, grows very quickly, and outgrows that valve. So I will have to see if I can put another one. So it is not a treatment that is soundproof. I have to come back, and I also have to take care of that valve. So basically the treatment is there, but it's not foolproof. So that is mitral regurgitation. That is the common condition in children. That is what you will see as making more noise about. Mitral stenosis is seen in adolescents. They will have moved to the adult people if they are here. But if you are in some hospitals where they keep them maybe up to 16, 17 in the children's ward, then you still have to take care of them. And so mitral stenosis is usually the second lesion that is seen in children. It's not as common as mitral regurgitation. the valve leaflets are very thickened, so they had mitral regurgitation and serial more sore throat, so they didn't get healed. So the valve decided to heal on its own. It is thickened, and the leaflets are fibrosed, and they just cannot move, and there's calcification. So if you take that pathology, then we can actually work on the physiology. So what happens? The mitral valve, I said, opens in diastole to allow blood to come in, and then it closes and it pushes the blood, the left ventricle then pushes the blood in systole outside to the aorta and the rest of the body. So the mitral valve is opened in diastole. If there is mitral stenosis, then the valve cannot open well. Okay? So the structure that suffers is the left atrium. The left atrium dilates, and it doesn't have thick walls. So the next structure that can make the child survive is the right ventricle. It has to dilate and hypertrophy in order to push blood across the pulmonary tree into the left atrium, into the left ventricle, and then out. So by the time the right ventricle pushes that blood, it is in the middle of diastole. Okay? So the murmur of mitral stenosis is a diastolic murmur. The murmur of mitral stenosis is a mid-diastolic murmur. The murmur of mitral stenosis is a mid-diastolic murmur that is best felt at the apex where the mitral valve is. Okay? The symptoms of mitral stenosis are those of the lungs and the rest of the body, the abdomen and the liver. So the children will come with cough, difficulty in breathing, because they are symptoms of the lungs, and they come and they are treated for pneumonia. Today, severe pneumonia, they're admitted, given oxygen, feels better, goes home, comes back again with cough, difficulty in breathing. Oh, it had said this is very severe pneumonia, gets treated, but somebody should listen to that heart. If you listen to that heart, then you'll now go beyond ITAT, and you will get more additional information. They really have severe lung congestion and lung fibrosis. So this is a picture of mitral stenosis. This is the left ventricle. This is the mitral valve, which can hardly open. It opens like a fish mouth. Okay, that is severe mitral stenosis. At least this one can play. And like I said, this is the mitral valve. It is not opening. You can look at the next valve, which is the tricuspid valve, and for true, it is opening. Compare it with this one where the cursor is, it is not opening. This is the left ventricle. This is the left atrium. This is the right atrium. This is the right ventricle. This is the wall that separates the atria. So this is the atrial septum. This is the wall that separates the ventricles. It is the ventricular septum. You can see that the left atrium is really struggling. There is a lot of smoke there. The right atrium isn't it. There is no smoke. So the left atrium gets dilated. Sometimes this smoke develops into a clot, and we have issues. The left ventricle is so small, so the apex bit is not displaced. So we have a restricted filling pattern. We have a diastolic murmur, which is a mid-diastolic murmur at the apex with no radiation. And this picture is supposed to show you severe mitral stenosis with a very big left atrium. And this very big left atrium is where our symptoms come from. Back to anatomy. The left atrium, I said, was a posterior structure. It is close to the esophagus and the trachea as it bifurcates. And the trachea bifurcates into the left bronchus and the right bronchus. And the other structure that comes and perforates is the vagus nerve, which goes down, but the recurrent laryngeal nerve will hook around the bronchus and go up. So I have some structures which will suffer. If that recurrent laryngeal nerve which hooks around the bronchus goes back, the left atrium was there dilated, it presses onto the recurrent laryngeal nerve and they come with hoarseness. So this patient presents to you initially with hoarseness. You say all the hoarseness belong to the ENT, so you take this patient to the ENT. They do everything including that and examination under anesthesia, but they don't find much. So they bring the patient back to you. Please re-examine the patient and you'll find that you send the patient without examination. So what are the examinations that we'll get? Let's start from the pulses. But before I leave the left atrium, this left atrium with this smoke can form a clot. So the patient with mitral stenosis can present for the first time with stroke. So when I see a patient coming with complaints and symptoms of stroke in the young, I must look for any issues in the heart also. I said recurrent laryngeal nerve, so they come with hoarseness. The esophagus is behind, so they come with poor feeding, and apart from poor feeding, can't swallow. They have dysphagia. They just have symptoms which don't resemble what we the heart. And this left atrium, when it is so enlarged, it sends bad blood to the lungs. So the lungs are congested. So patients with the mitral stenosis will present to you with hemoptysis. They cough blood. And we were taught that if you cough blood, most likely it is TB. And also that common things are more common. TB is more common than mitral stenosis. So these patients come with the history of having been treated for pneumonia and TB for 1 year. Pneumonia is such a grateful thing that if you treat it within 1 week, with antibiotics within 1 week, it doesn't. So if you have recurrent pneumonia, think twice. Recurrent infections, think outside the box. Outside the box, examine the heart. Okay? So they present very differently with multiple presentations. And so when we examine this patient, if it is mild mitral stenosis, they might be asymptomatic, but they present with dyspnea and orthopnea and palpitations and poor exercise tolerance and progressive heart failure. And like I said, it mimics a lot of symptoms, including stroke in the young, including vomiting, including vomiting blood, several symptoms that can worry us. But when we examine them, the pulses are low volume. You can't even feel them, and they sometimes are irregular because they can be in a condition we call atrial fibrillation. The apex bit is not enlarged, but the right ventricle is the one which is enlarged. The right ventricle is on the parasternal, so we have both left and right parasternal heave. The second heart sound is loud. I will not insist on an opening snap, but I will want you to appreciate the diastolic murmur. These patients are all in ward 4B. They are waiting treatment. So if you walk in 4B, you'll find children and adults with mitral stenosis awaiting surgery. The chest has crepitations, and they also have heart failure, so they have hepatomegaly. If I do a chest X-ray, I will see a heart which is not enlarged, but the pulmonary congestion will resemble even TB. So there are a lot of pulmonary vascular markings and interstitial edema, the kind we say the Kelly B lines. The left atrium and the right ventricle are enlarged, and the pulmonary vasculature is prominent. These are some of the complications of mitral stenosis. This is a stroke waiting to go. This is a valve which is not opening, and this is a this is a patient in intractable heart failure. So those are some of the terrible pictures I kept to show you. But sometimes we have mixed valvular disease. mixed mitral stenosis and mitral and tricuspid regurgitation. Unfortunately, this picture is not playing, but mitral stenosis gives us a small ventricle, and these are some of the complications of the mitral stenosis and mixed disease. The treatment is medical. We want to restrict physical activity, and we want to prevent stroke by giving anticoagulants. We want to slow that heart rate, and we want to manage the pulmonary edema when we are doing the medical treatment. But medical treatment is palliative. It only helps the patient for a while. So the surgical treatment, this is what we did today. This is an example of, this is not the exact patient, but this is mitral valvuloplasty. We pass some catheters through the mitral and we get across the valve and we open it up with balloons. This is called percutaneous mitral valvuloplasty. We do it regularly as soon as we get the patient and is suitable. So the treatment, we do closed valvotomy, we do open valvotomy. That is surgical treatment. We repair the valve and sometimes we replace them. So that is mitral valve disease. We have mitral stenosis and mitral regurgitation, and then we have that transition of a mixed disease of mixed mitral stenosis and mixed mitral regurgitation. Okay. I think you can put questions in the chat box, and as soon as we finish, we'll try and answer them. I will try and see how to get them from this other one. The aortic valve is that valve which opens to allow blood to leave the heart and go to the rest of the body. The aortic valve opens in systole and closes in diastole, opposite to what the mitral valve did. The mitral valve opened in diastole and it closed in systole. The aortic valve opens in systole and it closes in diastole. Don't confuse them. So the aortic valve has three leaflets which are equal. That is the anatomy. The pathology is that the leaflets then get eaten, so they are thickened and they can't close. This is a nice normal leaflet closing and opening well, but when it doesn't, this is the aortic valve, it then doesn't close, and so the blood leaks back. The blood leaks back in diastole when it is supposed to close. Remember, it closes in diastole and opens in systole. So the blood leaks back in diastole and gives you aortic regurgitation. So aortic regurgitation, when you can have mild regurgitation, moderate, and severe. What they normally have is a heart that is beating fast, which is called palpitations. The feeling of a heart beating fast is palpitations, but they have very poor exercise tolerance. They can't give so much, and they have dyspnea. You tell them to take another step, they look at you first before they move. They are wondering, where is this energy coming from? And they have chest pains, and they are usually chronic heart failure. The examination of the aortic regurgitation is quite perplexing and interesting, and the medical students should learn to pick at least something. Unlike mitral stenosis, stenotic lesions will give you low volume pulses. You are allowed to cram that. That stenotic lesions tend to give you low volume pulses. So if the pulse is not low volume, then chances are it's not mitral, it's not a stenotic lesion. So aortic regurgitation has bounding pulses, and they are wide. They really hit you. You can even feel the femorals shooting, the Corrigan's pulse, and the piston shots. And if you look at the nail bed, you appreciate the pulsations. That's called the Quincke sign. With every heartbeat, the head nods. That is called the Durosis sign. It's got a lot of signs, but which we want you to know. And it has a wide pulse pressure. You take the systolic blood pressure, it will be 100. The diastolic will be 40. A very wide pulse pressure. Yeah? If it is very severe, 130. The patients have got very poor exercise tolerance. And the clinical signs of aortic regurgitation, once you have felt them, you'll never forget them. The apex beat really now is displaced. A lot of blood gets back to the left ventricle. The left ventricle struggles. So it has to dilate, it has to hypertrophy. So the apex beat, which is a feature of the left ventricle, dilates and is displaced downwards and laterally. There is a thrill in the left sternal border because the aortic valve is on the left sternal border, and the murmur is diastolic, and it is diastolic which radiates back to the apex. And it is when the regurgitation is severe, then it gets longer. Those are details. What I want you to remember is that aortic regurgitation gives you a diastolic murmur. Unlike mitral stenosis, that murmur starts the moment the valve closes. So the moment this valve closes, the murmur starts. So the murmur of aortic regurgitation is an early diastolic murmur. And so the moment the valve closes, the murmur starts. So it is an early diastolic murmur. Mitral stenosis, I told you, was a mid-diastolic murmur. By the time that ventricle pushes the blood through the lungs to pass through the mitral valve, it is in the middle of the cardiac cycle. So those two things I'd like you to remember. Chest X-ray just shows us a very big heart. The pulmonary vascular markings are not affected. The aortic valve is difficult to treat. Medically, we might slow the heart rate, restrict physical activity, make it easier for blood to go to the systemic circulation by giving you AC inhibitors. Don't give AC inhibitors in mitral stenosis, you'll kill the patient. But in aortic regurgitation, the physiology is such that you can open the peripheries for blood to flow, okay, after load reduction. Okay. We add digoxin to reduce the heart rate and diuresis to reduce the fluid which can't be pumped back. The treatment is just to remove that valve. Repairing it is still difficult, so it is replaced. It can be replaced with a mechanical valve, with a metal. It can be replaced with tissue valves, bovine for cow and porcine for pig. So if you are the surgical registrar in 4B wanting to do cardiothoracic surgery, we will send you to look for the tissues. So we send you to Dagoretti where they have the whatever, and you harvest all those hearts, and then you come back and you clean them and you sterilize them and you trim them well. You remove all those funny cartilages and the rest of it, and then you size them, and then you sew them onto a metallic ring, and that is the bovine tissue valve. Or you go to Uplands and Limuru at the slaughterhouse, you say, me, I just want the pig heart. They say, what do you want to do with the pig heart? Take it, we don't use it. And you take it, and you go and trim the heart, the aortic valve, and you clean it well, and you sterilize it, and you size it, and you put it, and that is what is used to replace, and you put a string, and that is what is used. So tissue valve, they will degenerate with time. The tissues the body can decide it doesn't like it and put all sorts of antibodies. They have all their stories, and so they degenerate faster. And you are called when the child has reached. You placed it at 8 years. The child reaches 18 years, and you have to put another one. There is this pulmonary autograph. Autograph just means from the same body. So we take your pulmonary artery and we put it onto the aorta, because the left side, the right side, and we put it, and then we find something, a valve to put on the pulmonary side. That is also, they've also tried. Also, they say, all these things don't work, they don't last. So they say, why don't we go to the mortuary? That time, instead of going to Dagoretti or Limuru, let's just go to the mortuary, city mortuary here, or the Kenyatta mortuary, get the body of some human being, and then get the aortic valve, and that is called a homograft, the same Homo sapien. And that is some of these treatments have been offered. As you can see, none of them is satisfactory. Some of them, I talk and you feel, that one is strange. But those are the treatments that we do give. In Kenyatta, what we have been doing is to do the metallic prosthesis. And that's what we have. We have never passed any laws in the parliament to allow all this. So we only use the metallic prosthesis. In other countries where they have these other laws, you can decide and put in your ID when you are big enough at 18. You say, me when I die, you can take my eyes and give it to somebody, or when I die, you can take my kidney, or when I die, you can take my heart, and when I die, you can take my lung. Whatever you say, that is what they will take and give somebody to continue living. So those are some of the things we don't have here. If I put it, if it went to parliament, I think it will be thrown the next day or the same day. So those are the things that happen to this one. So you can see that rheumatic heart disease, it's a bad disease. That's the truth about it. And when it occurs in childhood, it is terrible. It has no cure, as you have seen. The therapies that we give, whether surgical or what, are short-lived. So the best thing is to prevent that sort of. If you manage, you can see how the prevention is what helps this patient. That is why when we have found these patients with features of rheumatic arthritis, we permanently put them on penicillin injections to stop any streptococcal pharyngitis. Any questions? How do I look at where people? Let me see what. I'm not seeing any questions, and like Zoom, I don't even know where to check the questions from. There is no chat box or anything. Where do we put? Have you people put questions? You can read for me and I'll answer.
Doc, I have a question.
Any questions?
Yes, Doc, I have a question. Other than rejection of the graft, I guess complications like it's just not working, or what other complications can there be?
Complication like?
Apart from graft rejection.
Well, in the treatment.
Yes.
The graft rejection is a very late thing. The first complication is that the child grows, but all those things don't grow. So it is a short-term treatment. It is not a long-term treatment. It's a very short-term treatment, and that's the first thing. Any other? So then the other complications were the other complications that we talked about, including the risk for infection and the infective endocarditis. If you put in the risk for a damaged valve has a risk for being infected. So when we have rheumatic mitral valve disease, mitral stenosis, mitral regurgitation, or a mixture of those, they can also be prone to infection. So infective endocarditis is common. They cannot withstand any other thing like anemia or anything. It gets worse. Any other question? Did I answer you?
Yes, thank you.
Any other question? Ask anything. Okay. The next lecture is when? Tomorrow morning. Still with this what is it called? This meeting, okay, I'll try. I survived today, I'll survive tomorrow. Okay, then. Thank you very much. See you tomorrow. Wake me up at 6:30. Okay, thank you.